All right. Hi, everybody. Dr. Nikita Vizniak, and I got to clear my throat here a little bit. Today, we're going to be going through thoracic outlet syndrome. So let me get my screen share done up. Of course, this information is coming directly from our orthopedic conditions manual, and we're going to be going through some specifics there. So on the ProHealth website, you can go ahead and have web access, or you can go ahead and buy the real copy, which you'll actually learn better from. But regardless, we're working here through orthopedic conditions. In the thoracic chapter for thoracic outlet syndrome, page 232. Somewhere right about here should be okay. Ooh, is it a postural syndrome? I don't think so. I think we're here for thoracic outlet. Okay, so a couple of key things. You should know the basic anatomy of where the thoracic outlet is, and there is some confusion around even this naming right here, but for the purpose of this discussion, we are calling this upper portion right up here where your first rib is wrapping around to the sternum, and you can see that first thoracic vertebrae as the thoracic outlet. Strictly in anatomy, we often will call it thoracic inlet, but don't even worry about that. This is thoracic outlet syndrome. One thing to get for this, it is a syndrome, which means that it is often overdiagnosed, and it's kind of a catch-all term for many different potential pathologies. You will be better off to label the specific pathology. If it was a scalene issue, if it was a first rib issue, if it's a pec minor issue, if it's somewhere further down the chain, or even some IVF encroachment coexisting, we're better off to give anatomical names for more specific structures involved than we are to just say thoracic outlet syndrome, but it is often diagnosed, and I would suggest to you overdiagnosed. So physiology, there's main three types that we have to worry about. The first one, and by far the most common, is going to be our neurologic, which could compress anywhere from C5 to T1. Now, having said that, it's normally involving the lower portions of the brachial plexus. So usually you're going to see that kind of C8, T1 area that's involved, possibly C7 most commonly. The next thing we have is a vascular secondary to subclavian artery and vein compression or thrombosis. A little bit more rare, but I will show you an angiogram later on that shows where this one could be. And then nonspecific symptoms of TOS is pretty common. And you might see that they have symptoms of numbness and tingling to the hand, weakness with overhead activities, as we'll see in a little bit. But the nerve conduction studies come back as within normal limits. That would point me more towards a vascular compromise. But again, we'll get into the treatments and ideas later on, and we'll see there's lots of options that we can have for people. The biggest thing is that patients actually get the right help first. So just as an anatomy review, we can go ahead and remind ourselves that we have an anterior scalene, a middle scalene, and a posterior scalene. And in between the anterior and middle scalene, we have this thing called the brachial plexus. That also has the subclavian artery, and out in front of it is the subclavian vein. And then anterior, we can see the phrenic nerve, your old friend going to the diaphragm. See 3, 4, and 5, keeping that diaphragm alive. I have drawn on this picture because it's there in about 50% of the population, scalenus minimus. If you want to look that up, you can. We have discussions of it in the muscle manual as well. But about 50% of the population has a scalenus minimus. And realize that on a real cadaver dissection, which you can also find on our website for this area, all of this region is actually filled with lots of adipose and connective tissue that also fills this up. So when you're palpating on somebody into that brachial plexus region or thoracic outlet, just lateral to the scalenes, you are over top of the scalenes, you are pushing on a lot of other tissue in there as well, a lot of lymphatics in there as well. All right, demographics. Who gets it? This is actually a fairly common condition. You're looking at about 1% of the population. Neurologic, 90 to 97% of the times, age 20 to 50, and it is far more common in females than males, although depending on the activity, even in bodybuilders, I see it with increased muscle mass and stuff too. So it's, happens in both genders. Venous type of roughly 3 to 10%, and the arterial type less than 1%. And that makes sense because in order for you to actually block an artery, it takes a lot more pressure and compression versus the veins. Yeah, those are relatively easy to compress and change blood flow in. And again, we'll show the angiogram in a little bit. All right, what do I have to know? Well, risk factors. Number one, posture. That rounded shoulders position, head forward position, people are often trying to take the pressure off of their neck, off of the scalenes. They could have tight levator scaps. Pec minor issues can be there, large breaths pulling down into the rounded position. But we're going to talk about this in a little bit too to make sure that you don't over exaggerate this. A lot of people will claim pectoralis minor involvement when I actually have my pectoralis minor, which as we know originates off the coracoid process, ribs 3 to 5 most commonly, although there is anatomical variation in that. What will happen is if I have rounded shoulders, that's me taking pressure off of my brachial plexus right there. I'm rounding my shoulders, That brings my coracoid process forward and means I don't have as much compression on the brachial plexus. It actually makes the hole where the brachial plexus is running through below the clavicles larger. So it's a pressure relief position. And we'll see this as one of the special tests in a little bit as well. Respiratory patterns. If this person is breathing hard because they've got some type of emphysema or asthma and they're pulling in air, that means the accessory muscles of respiration, which are the scalenes, will be involved and could be hypertrophic or myospasm in orientation. So either way, there could be a little bit of potential interruption right there. You can also be looking at first rib issues, extra ribs. We'll show an x-ray of that here in a second. Elongated transverse processes. Extra ligamentous tissue is quite common in that area as well, when I was talking before about all the tissue that fills that space. Prior trauma, whiplash, or damage to the first rib, clavicle can be involved as well. Humeral dislocations a little bit more rarely, but can tug on the brachial plexus a little bit. And scar tissue formation for any kind of damage into this area, whether it was surgical or impact trauma or lacerations, could be there. Anatomical variations with the scalenes and fibrous bands are something you should definitely take into consideration here. And then sleeping position, especially if the person lays face down with their arm above their head. So if I'm sleeping like this and laying face down like that, that puts a lot of stress and is in fact like one of the provocative tests that you can see over here. That is exactly like a ruse test, elevation abduction stress test right there. That puts a little bit more load over top of that brachial plexus and puts more stress through the thoracic outlet and could also exacerbate symptoms. So please evaluate sleep postures in these patients. History, you are looking at probably a very gradual onset of numbness and tingling. Now, this is where it gets a little bit tricky, because where is that numbness and tingling? So you're going to ask the question, do you have any numbness and tingling? Yes, I do. Usually it's in the ulnar side right here. So that's a tricky one to get, because now I have to differentiate a ulnar nerve lesion and a C8 radiculopathy as well in my evaluation, which you can do, relatively easy to do, but be aware that a lot of conditions can mimic each other and present the same, but they have very different causes. Other thing you'll see is the person might have like abnormal sensation. They might be shaking their hand a lot or moving their shoulder around a lot to take the pressure off. They might also have associated neck pain and headaches. So they're basically feeling the tightness as you go through and do your palpation and evaluate that area. You'll feel that tightness. Again, that history of cervical trauma, that whiplash, cervical acceleration, deceleration, sprain, strain is going to be there. Or more commonly, prolonged activities sitting at a desk, whether it is computer programming, playing video games, whatever it is, they're just stuck in this position the entire time, right? And symptoms are usually worse with shoulder abduction. This is across the board. Again, on our cadaver dissections, we kind of show where that happens a little bit, where you stress underneath the brachial plexus. And here I've done it as a drawing, where you can see the brachial plexus has to actually wrap underneath as we abduct the humerus underneath that pectoralis minor. But this only really becomes a player when you get past 90 degrees of shoulder abduction. All right, what else do I see? Physical exam, postural evaluation will show the postures that we just talked about. You might also visualize hypertrophic SCM or scalenes if they're really huffing and puffing and using those muscles hard, like in emphysema or asthma. Definitely palpate this area. Always a good go-to right here. So palpating over the scalenes, you might just feel ropey bands running right in front of those scalenes or right over top. Of course, hypertrophic muscles. Possible tissue mass. I have seen a few patients with lipomas in these areas that could also be coexisting. And another place you'll see this is on people who are quite overweight. So obesity and bodybuilders, just because of the increased mass of the tissue in that area, what winds up happening is it gives you more compression. So any kind of movement is going to potentially lead to more compression of the brachial plexus. Motion, active range of motion may be limited due to pain or exacerbate symptoms, again, especially past 90 degrees of shoulder abduction with external rotation. Muscle tests may show weakness depending on specifically the fibers that are involved and the nerve roots potentially that are involved. A grip strength with a dynamometer is not a bad idea. Realize that the dominant hand should probably be about 10 to 15% less than the dominant hand should be 10 to 15% more than the non-dominant hand. Deep tendon reflexes are usually within normal limits unless you have an extreme variation of it. Hyperesthesia, usually C8, T1, can be C5 to C7, but like I said, you're usually looking for that lower brachial plexus injury. When we're looking at the stretching of the brachial plexus underneath the pectoralis minor here, it would be more the lower part that gets more of that stretch. You will also see decreases in pulses, potentially atrophy of muscles. These are long-standing cases. The pulses one is tricky. You also have to worry about Raynaud's phenomenon as well when you're looking at this. But regardless, this one is going to change in almost everybody. It's why a lot of the orthopedic tests for thoracic outlet syndrome actually have poor statistical reliability. They're actually crap tests in the vast majority of cases. Yeah, that's right. I said it. They're garbage tests if you look at the stats behind them. Differential diagnosis, carpal tunnel syndrome, cervical radiculopathy, with or without herniation potentially. So it could be osteophyte formation or IVF encroachment from DJD. You could also be looking at vertebral dysfunctions, subluxations if you wanted to. Shoulder pathologies have to be ruled out. Ulnar nerve compression at the elbow could mimic this potentially. Multiple sclerosis in rare cases. Tumors on the spinal cord, again, very, very rare, but differentials there. Angina pectoris, myocardial infarctions potentially. But by the time you're out here, if it's left-hand side, maybe that's the more common picture for men, but maybe not so much for women. As we go up, best special test, if you look at the research, it's pretty clear it's going to be RUSE or the elevation abduction stress test, also known as the EAST test. Most reliable. So you're taking your patient, you're saying, hey, I've done all my palpation, range of motion, and muscle testing and all that. I get you 90 and 90. 90 at the shoulders, 90 at the elbows, and I have you gripping repetitively for 3 minutes. Now, if you've ever done this test in real life, 3 minutes is a long, long time. What I would suggest to you is you're probably going to see symptoms within about 30 seconds, either numbness and tingling, reproduction of symptoms into the hand, or the shoulder will start to drop, or they'll start to feel weak and just say, nope, I can't do it anymore. So that's going to be that one. Other tests we'll get to in a second: Adsons, modified Adsons, Wrights, Edens, a military brace test, and a TOS relief maneuver are all good tests. They offer many false positives, however. 92% of asymptomatic patients will show decrease in pulse when you lift the hands above the head. I mean, this is just basic physics. It boggles my mind how many therapists and doctors I see that think these tests are reliable, when in fact, if you just do a Wright's test, hyperabduction, I'm palpating your pulse, lift your hand above your head, it is normal for the pulse to decrease. That doesn't help me very much. What helps me is reproduction of symptoms. The other test that you might consider, and I think is a great test as well, is a focal stress test, or sometimes you'll see it called the doorbell sign. Literally, you find the brachial plexus right just lateral to the anterior scalene, and you push in and you go ding dong, hitting the doorbell. And what happens? It gives you symptoms down the arm where you get numbness and tingling taking place. So those will be some of your key orthopedic tests. I'll go through those in a little bit more detail here in a second. Again, reminding you, pectoralis minor, that every massage therapist with their blinders of bias thinks muscle all the time, is really only involved when you get above that 90 degrees of shoulder abduction. All right. Let's go ahead and look at some other more advanced imaging that you might do, should it be available. On a simple level, you could take x-rays. X-rays may show you cervical ribs, which is what we have here on the left-hand side, or an enlarged transverse process as well. On most x-rays that you get, though, they will not show you them outlined in pink like I did on this film from one patient. What you'll actually be looking for is this simple film like this, where you can see the new joint margins. This one's actually pretty neat. This person's got a bipartite extracervical rib right here. So you can see one rib bone right there, and then there's a joint, and then another rib coming up forward here, all deep to and under the clavicle. Pretty cool, actually. Pretty rare, but pretty cool. I think one estimate that I read recently was something about 10% of the population might have cervical ribs. So that number is variable, but depends on who you read. If you should have it and you've gone through your conservative care and you need more diagnostic imaging to help figure out better what's going on, you could also look into MRI. And MRIs can show you ligamentous structures or other sources of pressure over top of the brachial plexus, which is what we see here. If we go up even more invasive, because realize you're injecting a dye into the blood vessels here for this one, but you can see an angiogram that can show you emboli, that can show you arterial and venous obstructions potentially. And that's what we're seeing here. Also, Doppler ultrasound can be of benefit, and potentially nerve conduction velocity testing can be done as well. If the pathology is secondary to a nerve injury, then this will be a positive test. So I will get you through your full gambit. But again, x-rays, all these MRIs, angiograms, Doppler ultrasound, you're way down the road right here. You want to try your conservative treatments first and see how things are going. So number one, easiest thing to do is going to be simple rest and activity modification. Usually in the history, they're associated with some type of overhead activity. See if they can switch sides to the opposite side. It sounds crazy, but even something as simple, like I see this in drywallers quite commonly. If you got a lighter drill, you're working with that drill all day and that drill's like 5-10 grams lighter, that can be enough to make a difference for somebody. So work modification, tool modification can be there. Maybe looking at finding different tasks you can do on the job site as well. Weight loss, if axillary folds are cause of compression, or again, just being aware, just telling a bodybuilder, hey, part of the problem here is just because you have this increased muscle mass. So, once they get off their cycle of steroids in a lot of cases, then they'll see that the symptoms actually go away for them as well. You can consider short-term NSAID use for pain, but realistically, it's just a Band-Aid, not really solving the problem. Massage therapy is an excellent choice. Let me just say that again. Soft tissue work and massage therapy is a fantastic choice in these conditions. Anything that I can do to get you breathing better can relieve stress. In fact, if you're following along, I've been chatting for a while right here. We should just go through a breathing exercise ourselves and see how we feel. Big breath in through the nose, breathing out through the mouth. If you have a patient who's holding stress in the upper neck and trapezius area right here, which a lot of people do, the breathing can be of benefit. If they're ultra sensitive, you might start off with some manual lymphatic drainage, just super light stroking actions over top of the area. Myofascial release, you could also get into some trigger point therapy. I am a big fan of pin and stretch, so I'll actually anchor, pull the head over to the side, while I have the patient breathing is going to be a win. Joint mobilizations are also going to be of huge value in these patients. We know that it can involve ribs, it can involve vertebral movement. This cervical thoracic region, extremely tight on a lot of people, especially when they've got the anterior head carriage and they're all over like this, working on a computer or whatever else it is. Especially when they're in those positions, we have a lot to offer with our mobs in that cervical thoracic CT junction area. For some patients where it's really severe, I've even given cervical traction collars that you can just buy that pump up and give that little bit of traction, but they're only short-term use only, right? You want to get them through their acute pain and then get them working on more flexibility and range of motion. There are lots of acupuncture points, but I would be very cautious with acupuncture in this area because there are a lot of fairly important structures, little things like the roots of the brachial plexus. You can also see things like your carotid artery and external and internal jugular veins that I probably don't want to be jamming needles through. Surgery is an option, but again, you should be out 6 months, 8 months before you're even looking at surgical options here of an honest attempt of good conservative management. Rehab exercises are going to involve stretch and strengthen, maximizing outlet space. So anything that I can do to open up this area in the neck, yoga is going to be a great choice. A little bit of Tai Chi to start with. I will get people into partners yoga and partner stretching. And believe it or not, Brazilian Jiu-Jitsu, different chokes and movements of the neck are going to move you around and give you forced partner-assisted stretching is what I call it. Forced yoga, Brazilian Jiu-Jitsu. What else? Strengthening of trapezius and rhomboids, even working on just simple retraction exercises for the middle back and getting them to move those areas around. We'll see where some of the orthos come in here as well. But even just lifting up the scapulas and moving your shoulders around like this. If I move like this is actually from a military brace test. I would lift my shoulder up. Well, my clavicle, which I'm outlining right here, lifts up and takes pressure off. Bring my shoulder back and then bring it back down. Just exploring these ranges of motion are going to give a self-massage to that brachial plexus where the thoracic outlet is. Postural exercises are going to be great, absolutely. And then relaxation techniques, back to the yoga and back to the breathing techniques. Things you can do on your own. Prevention, light activity using the arm and hand is encouraged. So keep on using it, but using it in a slightly different way. Avoid the heavy aggravating activities. We say 2 to 3 months here. Even if you gave an honest 2 to 3 weeks, that's usually enough to get people over top of their acute pain syndromes that they might be into. Ergonomic evaluations in the job place are foundational, whether it's at a desk, whether it's at a manual labor where you're moving and tossing sheets of plywood or whatever else it is. You definitely want to evaluate how you move and find different ways to move efficiently and avoid the repeated stress in the area. And that's what we're saying here. Avoid the overhead repeated activity or change sleeping position. Oh my gosh, how many patients have I helped solve their TOS by saying, hey, let's just not have you sleep in this position anymore, face down, okay? Same thing for carpal tunnel. I got a couple of patients already this week where one of them in particular was sleeping down like this, and she was just compressing her, like laying like this on the mattress and compressing her carpal tunnel the whole night while she's sleeping, wondering why she wakes up with numbness and tingling into her fingertips. Well, there you go. Prognosis is excellent for this condition. 90% of patients will improve with conservative management, multidisciplinary management. So you can give that out there. You can say the vast majority will get better if you do these exercises. That's motivating enough. Rarely do you need surgeries for these more substantial conditions right here. Again, give me an honest 6 to 8 months at least before we go surgical interventions. If we look at some of the exercises, they are simple, but the key thing is getting people to do them. Great for the neck, the overhead neck stretches, where you're grabbing and pulling your head to the side, pulling down for more of the posterior structures, looking up for more of the anterior scalene structures right there. Good shoulder mobility stretches are going to be key as well. Doorway stretches, like I already demoed, shoulder rolls, where you're lifting the shoulder up and down, front and back, moving the arms around. You can do small push-ups using serratus anterior, where you're just doing small little punching movements. So I would just be shoulders back, shoulders forward, shoulders back, shoulders forward. Realize when you're doing this, the clavicle is moving back and forth each time. I love these doorway hangs or just hanging in general. And of course, get a dowel rod or a broom and just get used to opening up the shoulders, making that thoracic outlet be a little bit more usable, more open with relaxation of the muscles. This just feels good as an exercise in general for the vast majority of people. All right, back onto the TOS tests. I will give you the good tests and not so good tests. So this is coming directly from our orthopedic conditions manual right here. So if you have that, we give you more of the research and links and everything for that. But regardless, Adson's test, relatively low quality test, sensitivity and specificity way down there. I wouldn't even waste my time other than maybe to use this test as a way to stretch the brachial plexus, okay? In which case it could have some benefit for the person. Costoclavicular maneuver, also known as Eden's test, also known as military brace test, I think is actually a fairly good test. Specificity of 90 to 100% basically. And the way that this test works is elevation, retraction, and then coming back down, pulling down the clavicle. This would be analogous to your patient with a heavy backpack that's always getting their shoulders pulled back and down, giving that extra weight and compression over the brachial plexus. TOS maneuver is pretty good. It doesn't have good research behind it, but biomechanically and anatomically, it does make sense. If I take and lift your arms up, so I take and you get your arms lifted up like this, that raises the clavicle up, makes the space around the thoracic outlet and compression on the brachial plexus substantially less. So theoretically, that could be involved, okay? Right hyperabduction test, okay. Again, specificity anywhere from roughly 40 to 90, so well across the board right here. You're going to see a change in pulses. Well, yeah, when I lift your arm above your head, same thing with Allen's maneuver, which is a variation of this test. I expect your pulse is going to decrease when I lift your arms above your head, which is why it's maybe not the best test. Shoulder depression test, low quality test. Again, what's your goal here? Theoretically, I am pushing down over the acromion on the shoulder. That's going to take the clavicle, push it down, and compress the brachial plexus. You'd be better off doing this costoclavicular maneuver where you do the movements all the way around, because it shows you relief and then getting the pressure right back on. So it's actually pressure off, pressure on, probably more diagnostic. Best test that you can do by far is going to be RUSE test, elevation abduction stress test, or provocative elevation test, whatever you want to call it. Good sensitivity, good specificity, 90-90. Theoretically doing this for 3 minutes, probably not in real life. All you're looking for roughly is reproduction symptoms, and that's going to happen within about 30 seconds. And be aware in all of these tests, the lower quality tests have like a 90% rate of false positives. So that means the general population doesn't have TOS, but gives you a positive result for the test. Excuse me. Even the RUSE East test will give you about a 40% positive rate in the normal population. You never diagnose this condition by any one test. And that's one of my biggest pet peeves where we see this overdiagnosed, is somebody will pick 2 or 3 crappy tests. They'll say, well, Adson's test and reverse Adson's was positive, which is known as a Halstead, were positive, and so was Wright's hyperabduction. Well, you just diagnosed this condition based on the crappiest tests right there. You're way better off looking at history, doing an East test, and then evaluating from those positions right there. If you still have a index of suspicion and you're in doubt and you're just not sure and the patient's not getting better, then you can go into more invasive assessment modalities, which include the X-rays, MRIs, angiograms, Doppler ultrasound, and neuroconduction studies. But you don't need to do that in the vast majority of cases. Massage, mobilizations, and exercises are going to be the win for the vast majority of patients here. The other thing is you always want to go back to biopsychosocial support. Make sure they have the support they need for this condition to realize, oh, it's relatively common. There's lots of things we can do, and we can make a big difference here. So with that, we get you through all the way thoracic outlet syndrome. Again, often an overdiagnosed condition. Try and be more specific. Is it more of a scalene syndrome? Is it more of a pec minor issue? Is it a clavicular? Like I didn't even mention this. You could have a clavicle fracture that has a big callus formation that could also be compressing on the brachial plexus. Try and find the root cause and give it a name for the root cause. That would help you out a lot in this condition. So that should get us through TOS, an excellent summary right there to get you through it. We have video of all the orthopedics. We have video of all the muscle testing you can find on our website. I'll thank you very much for your time right there, and we will see you in a future video, seminar, or textbook down the road, and hope you enjoy your day and get out there and help a lot of people. All right, cheers. Thanks a lot.